So the question about sequencing and combining Sipuleucel-T with other approved agents. So I'm very much of the opinion that immunotherapies are not only here to stay, but thanks to the development of Sipuleucel-T, it really heralded that new advancement for us, not only in advanced prostate cancer, but we're seeing that this now in other metastatic solid tumors. And for urologists and bladder cancer, we're seeing some really novel advances in immunotherapies. But getting back to the question about Sipuleucel-T, I think that there's been wonderful literature published by Dave Crawford, Adam Keibel, Chuck Drake, James Gulley, that treating patients earlier on in their M1 CRPC disease continuum is when they're most likely to get their greatest impact from Sipuleucel-T. There's potentially less immunosuppression, with a lower tumor burden, and these are the patients who will benefit most greatly. I've talked with Nick Vogelzang, and he also believes too that because the therapy is so well tolerated and over such a short period of time, I mean, a course of therapy is over in 4 to 6 weeks, although there's an upfront cost, this is why it's really best given it very early on. Nick and I both participated in the Prospect trial, which is a subcutaneous administration of another therapeutic vaccine known as Prosvac. He and I both have a series of patients who receive Prosvac and then Provenge. So we're going to follow those patients to see what kind of double impact or double whammy approach that will have in addition to other anti-neoplastic therapies they can have. But your earlier question about what about combining and sequencing Sipuleucel-T today with other approved agents. So first, I try to give it as early as possible in my M1 patients. Now we did 2 studies looking at combining and sequencing with abiraterone and enzalutamide. In the STAND trial, we called it, we had 30 patients who received abiraterone with prednisone concomitantly when they received their full course of Provenge, 3 cycles over 4 to 6 weeks. And then another 30 patients who received abiraterone 2 weeks after their last infusion of Provenge to complete the course. We just had that paper published, those 60 patients, and our findings in that in the AACR. So that just came on EPUB, it's online now, and it will be out in print shortly. The bottom line to that, and it was published with Emmanuel Antonarakis and Chuck Drake and several other authors. I'm just one of a really good group in that. What we really showed was a lot of good, interesting immunological findings, but one of the take-home things is that the ability to manufacture the Sipuleucel-T based upon CD54 upregulation, nucleated T cells, is that there was no difference whether it was given concomitantly or subsequently. So that's one answer to your question. We're following those patients out long-term for final efficacy. We did a very similar study, the STRIDE study with enzalutamide, about 40 patients, concomitant enzalutamide with Sipuleucel-T, and then giving enzalutamide 2 weeks later. We've presented this in large associations. We presented this at AUA and ASCO. We haven't published it yet. And again, we found no implications about the ability to manufacture Sipuleucel-T. So I think that that's very encouraging. They're small number data sets, but I think we at least get that out into the literature so clinicians can think about it. Bottom line is Sipuleucel-T is given so quickly in a 4 to 6 week period that I think for anyone right now who has any concerns, I think it's perfectly reasonable to wait anywhere from 4 to 10 weeks and then consider giving abiraterone and or enzalutamide. So you're asking what other immunotherapeutic trials are we involved in? So I'm very proud of my involvement with the phase 3 trial known as the IMPACT trial that led to the approval of Sipuleucel-T, also known as Provenge. I'm privileged that we were a high enrolling site for the PROSPECT trial for Bavarian Nordic, and that's the PROSVAC immunotherapeutic. And right now we have 2 trials that we're enrolling at my site. One is known as SODIO, and it's a combination of a dendritic cell vaccine with concomitant use of docetaxel chemotherapy for patients who've never seen chemotherapy before. It's an M1 CRPC trial, and we've already enrolled several patients. And then we're also about to start enrollment with a therapeutic strategy for patients who are just PSA biochemical relapse. And this is Inovio is the name of the company. And it's a series of intramuscular injections. And it's interesting in that there's potential that when you give an intramuscular injection, and it's a complex immunotherapeutic approach, but that it further expands the native immune system to incorporate the immunotherapeutic bolus. So what's nice about this, we're about to begin enrolling, and this is just in PSA relapse patients, still androgen sensitive, not CRPC. And these patients do not, this is a phase 2 study, do not have to undergo androgen suppressive therapy. So they can remain, eugonadal, which obviously has quality of life benefits to patients. I'm very optimistic about immunotherapeutic approaches because in my mind, teleologically, it really makes the most sense. If we can refashion, reinvigorate, harness our own innate immune system and not rely on something exogenous, but if we can really break the tolerance that's occurred, whether it's in the androgen-sensitive state or the castration-resistant state, then that really makes for quite an ideal therapy. I don't think that it's going to be anything that we're going to see in the very near-term future. And we'll probably continue to look towards sequencing and combination regimens.